Hello again. This is Rob, and we're going to be starting our fourth lecture. And our fourth lecture is going to be the start of our clinical series where we're looking at two disease states. In lecture 4, we're going to talk about an update in type 2 diabetes care. And in lecture 5, we're going to do an update in cardiovascular care. And one of the things that I hope as we go through this, you start to think to yourself for your pharmacy, what are ways that we can improve or add services to our pharmacy? Once again, there's my disclosure statement with no conflict of interest. And so the first part of this lecture, we're going to look at the updated guidelines that came out this past year. And we're going to talk about the therapeutic goals of type 2 diabetes to prevent long-term complications. And why is this important? Well, in 2010, the CDC ranked diabetes the 7th leading cause of death. The other thing we think about with diabetes is the long-term complications, which can lead to things such as kidney disease, kidney failure, amputations due to poor circulation, and unfortunately blindness. And the biggest issue, unfortunately, is type 2 diabetes goes undiagnosed for many years because hyperglycemia develops gradually at early stages, and we don't notice those classic symptoms. Type 2 diabetes can account for over 20% of healthcare spending, and obviously it is prevalent and is one of the most common forms of 90-95% of all diagnosis cases of diabetes. What is type 2 diabetes? We've all heard this before. The biggest issue of type 2 diabetes, especially compared to type 1, is it's not that the pancreas isn't working, is that for genetic reasons and some unknown reasons, we have developed insulin resistance, and this especially happens later in life. A lot of times it's associated with weight gain. And what happens is the pancreas is pumping out the insulin, but when the insulin shows up to the cells, that the cells are not recognizing the insulin to let in the glucose. The other thing that happens is the body thinks because the cells aren't getting the glucose in, hey, we're starving. And so what does it do to help improve that? Well, it fires up the liver to produce more sugar. And over time, the other thing that can happen is the pancreas cells can eventually start to slowly burn out, and we soon decrease our ability to secrete insulin, which eventually may lead to that patient going on insulin therapy. We classically think about the two different types of long-term complications, and these long-term complications are the result of years of uncontrolled diabetes with high sugars exposed to our system. And in clinical studies, it's been shown that if we can keep those sugars under control and tight, that we may be able to at least slow down the progression. In type 2 diabetes, it's been a challenge to slow down the progression of macrovascular complications such as coronary artery disease, cerebral vascular disease, and peripheral artery disease. Obviously, keeping the sugars under control can help slow down that progression, but a lot of times we have to do other interventions to prevent long-term complications. We'll talk about some of those in cardiovascular disease, such as controlled hypertension, controlled lipids, to be able to take care of that. In microvascular, the studies have been shown, especially in type 2 as in type 1, is that if we can keep the hemoglobin A1C under control, we can prevent things such as retinopathy, blindness, nephropathy, end-stage renal disease, peripheral neuropathy, which can eventually lead to patient unaware of maybe a cut or a sore, which can lead to a severe infection. And because we have poor circulation, we're not getting enough oxygen to that area. We can develop severe diabetic infections that are maybe anaerobic in nature. And this can often lead to amputations, When we think about the neuropathies, a lot of times we think about the tingling in our fingers, but this can also lead to things such as ED, gastroparesis, where we're not able to, our GI motility decreases, loss of bladder control, urinary retention because our bladder is not able to contract properly, and therefore an increase for UTIs. And in the worst case scenarios and macrovascular complications, we worry about, long-term things such as hypertension, heart attacks, heart failure, strokes, and peripheral artery disease. So, what are the risk factors? And it's never too soon to start screening somebody for the risk factors. Obviously, there is a strong genetic predisposition, so family history. Obesity is prevalent in type 2 diabetes. Weight itself can cause some insulin resistance, and having a good weight loss program, or maybe in your pharmacy or referring them to a weight loss program, maybe having a good relationship with a dietitian can help with that. Physical inactivity, and it seems that in race and ethnicity, African Americans, American Indians, Hispanics, Latinos, and Asian Americans are at the highest risk for type 2 diabetes. It is also a disease as we get older, we develop glucose intolerance, and so we're elderly are at higher risk. Obviously, the other thing that can be associated is having a low HDL in your lipid panel on high triglycerides, which can lead to possibly pancreatitis, fatty liver, and obviously we are concerned when we're reviewing patients if they have a hemoglobin A1C above specifically 6. A lot of times when the symptoms do occur, it's those classic symptoms that we learn about with hyperglycemia, and that is polyuria, increase in urination due to glucose in our urine. Because we're losing water, an increase in thirst, and also feeling hungry. Other symptoms can be included, such as blurry vision, difficulty concentrating, headache, fatigue, and poor wound healing. And if you take a look over on the right side here, some things, for the asymptomatic patient is we should be testing patients who are above their BMI, classified as overweight, and also if they have genetic predispositions, ethnicity, and especially for all patients, testing should begin at the age of 45 years of age. So, how do we confirm the diagnosis? Unless there's a clear clinical diagnosis, all right, for example, the patient in a hyperglycemic crisis or with classic symptoms of hyperglycemia, and there's a random blood plasma glucose greater than 200 milligrams per deciliter. But obviously, no matter what, if that occurs, a second test should occur for confirmation. It's recommended that the same test be repeated without delay using a new blood sample for confirmation, because there will be a greater likelihood of concurrence. The other thing is we can diagnose with a hemoglobin A1C. For example, if the A1C is 7% or greater and the repeat result is 6.8%, then the diagnosis of diabetes is confirmed. So it's important that we look at two different aspects as a clinician to see whether or not they truly have type 2 diabetes. Regardless, if they are high, we should be counseling the patient about prediabetes, even if they don't roll in. So let's talk about what are some of the fundamental things for managing type 2 diabetes. And one of the most important one is lifestyle management. All right. And when we think about, I talked about advanced clinical services, diabetes self-management education, a lot that goes into that program. And one of the things with diabetes education, if you get into it, you may also want to consider adding to the teaching faculty of your diabetes management program is a dietitian. And because the one thing the dietitians have been trained, and it's not that we can't be trained, but thinking about motivational interviewing, behaviorals of change, very similar to smoking cessation, because you need to empower the patient. Diabetes is a disease of responsibility, and a lot of times tackling lifestyle modifications after 40 to 50 years of doing the same thing can be a very difficult challenge to overcome. Recommendations obviously is smoking cessation, evaluating diet, making dietary changes, physical activity. All right, and what it recommends is engaging in at least some type of physical activity, 60 minutes a day or more, and possibly 3 days a week with vigorous muscle strength exercising. But most adults, what we do at least recommend is 150 minutes or more of moderate to vigorous walking. So even if they walked anywhere from 20 to 30 minutes a day, that can help at least contribute to it. The other thing is, when we're evaluating a patient about type 2 diabetes from a pharmacist's perspective, we should be thinking what are some medications that can raise blood glucose? So start thinking about that. Well, several different medications, and sometimes they are medications maybe we're able to remove, and sometimes based on other disease states we can't. Corticosteroids, we highly don't recommend the long-term use of corticosteroids, but in cases such as transplant patients, severe COPD, end stage of life patients, some cancer patients, that corticosteroids may be needed for long term. Several of our HIV medications can cause glucose issues. We've learned that when the atypical antipsychotics came out, we were very excited that these drugs didn't seem to cause the extrapyramidal symptoms, but we learned that some of the early drugs, like olanzapine, clozapine, quetiapine, have an association of possibly causing glucose intolerance. Some of the newer antipsychotics that have come out over the last 10 years, such as Abilify, seem to have less effects on the glucose panel. Thiazides and loop diuretics, they can occur. You obviously always should ask the benefit versus risk versus benefit. If I got a congestive heart failure patient, I may have no choice but use a loop. But thiazides, they raise the sugar a little bit, but not significantly enough that we would not see the benefit that it can add, especially in hypertension control. But there are other alternatives and better drugs of choice for hypertension control. We're going to talk about with helping prevent coronary artery disease. Statins is a corner. There has been possibly some association with statins raising blood glucose. However, the benefits that statins contribute to the prevention of macrovascular complications far outweigh that, and the evidence of statins causing diabetes is very questionable. Antibiotics, because they're short term, but anytime we're recommending like cough and cold preparations, we should, and if they're in a liquid form, trying to go for sugar-free. The other big thing to think about with this type of patient is comprehensive care is a key, especially in preventing macular vascular complications. The recommendations recommend getting that blood pressure below 140/90. Although the JNC8 doesn't come out and say you have to definitely use an ACE and ARB every time. In fact, that's why they were removed from the Medicare star ratings. It is encouraged to use an ACE or an ARB in blood pressure control because numerous studies like the HOPE trial showed that it can be very nephroprotective. In fact, if a patient doesn't have hypertension but does show that it has significant levels of albumin in its the patient in their urine, they should start an ACE or an ARB therapy for that. And some of the reasons why ACEs and ARBs are nephroprotective is because they block angiotensin II right there at the arterioles, at the glomerulus, and therefore, besides lowering blood pressure, are taking down the pressure within the kidneys itself. Patients with diabetes should be considered statin therapy, and we're going to talk about in the next lecture about high intensity statin therapy, and they should be considered. And patients above the age of 40 should be considered adding aspirin therapy for primary prevention of cardiovascular diseases. Other things that we can do as a pharmacist is consider about things such as vaccinations. Patients with type 2 diabetes, regardless of age, should be getting hepatitis B, pneumonia, getting annual flu vaccination. Thinking about these patients should be constantly reevaluating their diet, exercise, trying to enter into a diet of more like a DASH diet, using the plate method where your portion control is more in green leafy vegetables, and your protein and your carbs are just a third of what you're eating in each diet. Other things that need to be recommended is that should have annual screenings such as retinopathy, diabetic foot exam. Important because patients who start losing filling in their feet can have not able to recognize cuts and sores, and therefore risk for possible infections, and this is what can lead down the road to amputations. The other thing should be checked periodically is a urinalysis to see if there is any kidney damage and whether or not there is a significant amount of albumin within the urine, and also reevaluating what their creatinine clearance is, their GFR, the glomerulus filtration rate, and seeing whether or not there has been any decline in kidney function. Another thing to think about as a pharmacist is, if you are looking, you are Medicare accredited, diabetic shoes is an option to think about. It's another ancillary thing that you can offer to your diabetic patients. And a lot of times, one of the best ways to do that is hold a diabetic foot exam, teaching patients how to test for their foot exam and looking at whether or not they have any neuropathies. Our overall treatment goal, and one of the things the new guidelines have kind of suggested, is that with the A1C, depending upon the type of patient, how stringent should we be? So for healthy, non-pregnant adults, keeping below 7% is probably adequate. Most of the original studies where they showed decrease in microvascular complications in type 2 diabetes, the goal was set below 7%. For more stringent patients, more younger patients, we may be holding A1C below 6.5%, especially if they can tolerate issues such as hypoglycemia. When we talk about patients with lower life expectancy, multiple comorbidities, the elderly patient, we're a little bit less stringent in those select patients and may be going for a hemoglobin A1C less than 8%. So, what are some other key points that the 2017 Standards of Care updated besides what I've just recently mentioned and have been already on the books, but they were just reinforced with this new update? One of the biggest things in the update is the importance of a comprehensive medical evaluation, making sure that the clinician or you, the pharmacist, assessed all comorbidities, the whole patient, that the patient is working on goal building, looking at their nutrition therapy. Are they looking at their carb intake, their fat intake, their protein intake? Physical activity is recommended. Children and adolescents with type 1 or type 2 diabetes or pre-diabetes should engage in 60 minutes a day or more of moderate to vigorous intensity. Most adults with type 1, type 2 should engage in about 150 minutes or more of moderate to vigorous intensity. The other thing is prolonged sitting shouldn't be interrupted. Should try to stand every 30 minutes. And if you look at a lot of our Fitbands, Apple Watches, that they actually have little beeps to remind us that if we've been sitting too long, we should stand. Other things within the update that is mentioned is that an increased screening efforts to prevent and delay type 2 diabetes. The earlier we can screen patients and prevent those years of going undiagnosed, which can lead to, an acceleration of those complications. If the patient, we're going to talk about drug therapy, is on metformin, metformin over the last several years have been shown to possibly decrease B12 levels. And although the benefit of metformin outweighs the risk of B12 deficiency, this should be evaluated because the patient, this is an easy correction with supplemental B12. And obviously, we know the signs and symptoms of B12 deficiency can lead to things such as, feeling tired, memory problems, hypertension treatment when the albumin is present, and they recommend any of the 4 blood pressure classes. The key ones that we recommend, we'll talk about those in the next talk: ACEs and ARBs, thiazide diuretics, and using calcium channel blockers, the non-dihydropyridines. The other thing is, depending upon the patient, is if they are a candidate, especially if they have a lot high BMI, they may be a candidate for bariatric metabolic surgery, but they need to make those classifications to be able to do that. Obviously, a BMI greater than 30 or 27.5, I take into, and they've been maxed out on their pharmacotherapy. The biggest thing with metabolic surgery that's been in the news, that is this possibly a cure for diabetes? Some argue that not necessarily, no. Maybe you might go a life without that, but you should always treat yourself as a diabetes patient, because we should be constantly thinking about those lifestyle modifications such as diet, exercise. Okay, so we've talked about the update in the guidelines. Let's look at identifying clear monitoring requirements for oral diabetes medications and those adverse events. Now, if you take a look at all the different oral medications, it is sort of the outside of metformin, it's kind of the wild, wild west of what do we use. On the injectable side, we're going to keep insulin separate in our discussion, and we'll come to that here shortly. But we also have some newer injections that help with the therapy, the GLP-1 agonists such as Byetta, Byrudian, and Victoza. The other thing that I want to just stress and mention as we go through these medication review is that the key thing is, throughout adding medications, that primary prevention is so important. And that, besides primary prevention for the macrovascular complications, but also looking at their lifestyle modifications, because these medications are only as good as the patient is addressing their diet and their weight issues. The other thing is, when I go through these, please look at the significance that these drugs may have on the hemoglobin A1C, because when we start talking about a lot of these new drugs like the DPP-4s, the SGLT2s, the GLP-1 receptor agonists, they're all expensive. They're all significantly expensive, where they are contributing anywhere to $300 and $400 in total cost of a drug. Maybe the patient's not paying that directly, but for those who we still worry about the donut hole in Medicare D, that if they're not getting any significant bang for their buck in lowering hemoglobin A1C, that we do know insulins are expensive too, but they have a significant greater reduction in A1C. And a lot of times people do fear the needle, but if I'm spending my money during the time I'm in the donut hole, insulin therapy may be the better option versus some of these newer agents. So if you take a look at the guidelines, one of the things they recommend, if the A1C is greater than or equal to 9%, possibly consider adding dual therapy to the patient right away. If the A1C is greater than or equal to 10%, all right, possibly considering injectable therapy such as insulin or the GLP receptor agonist. And I'll talk about the GLP-1 receptor agonist that they have been associated possibly helping contribute with weight loss. The first, obviously, if you notice through all the stages of the guidelines, it's recommending lifestyle management. The first drug, the cornerstone, is metformin, and I'm going to go through some of these drugs individually. So I'll go into a little bit more detail here. When we go into dual therapy, it doesn't really give you a clear which one to add, but sometimes you look at the different things. You look at its efficacy, and you look at its hypoglycemic risk. You look at its weight gain risk, which can be problematic, especially if a patient has a high BMI and they're struggling with just getting diet under control. You look at its side effect risk, and you look at its side effects risk compared to maybe other comorbidity disease states they may have. And then the last one, too, we need to look at cost. And triple therapy is listing and all the different combinations. You can take a look at that yourself individually. But like I said, once it comes after metformin, it's sort of the wild, wild west of what do we pick. But we can look at this clinically, scientifically, and logically if we take a look at how can we lower these, affect the outcome of the patient by targeting what might be better for that patient. So, biguanide, the only biguanide we have on the market anymore is metformin. The way that it works and why it's such a big cornerstone to diabetes therapy is it helps improve insulin sensitivity. It decreases intestinal glucose absorption. It helps increase peripheral uptake of glucose. And the other one is it decreases that hepatic glucose production that can occur in type 2 diabetes. Another advantage of this drug is that it does not cause hypoglycemia. And so when somebody's first starting therapy, they're not scared of, you know, of being on this drug. Well, what if I pass out when I'm driving? What if I pass out at work? And so it allows that patient to, start to slowly adapt being diabetic. The other thing is it doesn't cause weight gain, and possibly it may cause some weight loss. Now, a key thing with this drug is we have to slowly titrate the patient up because it has significant GI upset. So some of the pearls to do that is slow titration, or sometimes switching them to extended release product may help decrease this issue. But the other key reason why this is a cornerstone is the A1C reduction is between 1 to 1.5%, which in diabetes medications is probably one of the best compared to insulin. And we do monitor patients with renal. When this drug first came out, we were a little bit more scared about it 20 years ago than we were now, because if you remember, its ancestor fenformin had a significant ADR with lactic acidosis and association with death. We've learned over time that this is not as high of an incident. However, we do caution and contraindicated of using metformin in patients below 30 mLs a minute. There's been a big push. One of the problems with this drug is Bristol Myers Squibb, which was the original manufacturer of this, did not do any creatinine clearance guideline dose adjustments. There have been done, but not FDA approved out there in the literature. But that is. The other one is if a patient is a heart failure patient, it's no longer significantly contraindicated, but you have to worry about the increased risk of lactic acidosis. So if you do keep them on metformin, there should be close monitoring for that. Elderly patients, obviously we know elderly patients have a decrease in renal function, so this should be closely looked at and monitored. Now, the next drugs are classic drugs, the ones that we remember learning, first in school, at least I did, because metformin wasn't even out when I was in school, is the sulfonylureas. The sulfonylureas, the way that they work is they help stimulate insulin release from the beta cells right after a meal. They may see the downside is because the beta cells can start burning out is they can see a reduction in efficacy over time. The good thing is they're inexpensive. We highly recommend using the second generation agents, and we already kind of addressed this in the geriatric talk, because they have less risk for side effects, which is the hypoglycemia. They all can cause hypoglycemia, and they all have the potential to cause weight gain. And the reason why they cause weight gain is because we're increasing insulin. And so, that is why they're not recommended as the first drug of choice. Drugs that we try to avoid is glyburide, because remember, it is an active renal metabolite, and so we have to worry about renal dysfunction with glyburide. Glipizide is probably the best choice out of all of them. Glipizide also comes in an extended release product, and both glipizide and glimepiride have less weight gain. But if you look at, they still have a significant reduction in A1C of 1 to 1.5%. Now, one that has fallen out of favor over the years is the glitazones. Oh, another point about the sulfonylureas is making sure, and we're going to talk about this a little bit later, that we're counseling patients on how to treat and the signs and symptoms of hypoglycemia. Now, when the glitazones came out, they were a very popular drug. You had pioglitazone and you had rosiglitazone, Actos and Avandia. The downside of these drugs is that they possibly may increase weight gain and cause volume retention and heart failure. In fact, rosiglitazone was actually pulled off the market, slowly became an orphan drug, and has slowly been brought back on the market. However, because of that, what happened, the glitazones have kind of fallen out of favor. However, they're actually still pretty good drugs. The way they work is they help improve insulin sensitivity in the skeletal muscle and adipose tissue. They even help preserve beta cell function. The advantages, they also don't cause hypoglycemia, and they actually may increase the HDL, which is our good cholesterol. They actually have decent A1C reduction, and, like I said, the good effects is on the lipid profile. There's some evidence possibly in the literature of Actos of increased risk for bladder cancer, though that risk is very, very low. There was the study with Avandia may having an increased risk for MI, and that's why it's generally not used besides the heart failure. However, you go back and look at the data that studies, it's very questionable. But because of all that, Actos pioglitazone seems to be the drug if we do use it. The disadvantage is we want to avoid this drug in heart failure patients. There has been possibly some association with fracture risk with pioglitazone. And in rosiglitazone, even though I told you it increases HDL, there was some evidence in studies that it may increase LDL. But Actos also is another drug that we don't have to worry about renal function. So it's one of the very first ones we don't really have to, whereas metformin and the sulfonylureas we do. The other key one with the sulfonylureas of Pearl we all know is we usually tell them to take at least 30 minutes before a meal, so that prevents hypoglycemia. Then we think about the DPP-4 inhibitors, which have been very taken off like wildfire over the last couple years, and maybe even a little bit longer than that. And how do they work? Well, they increase insulin release, they decrease glucagon secretion. The downside of these drugs is that, that their reduction in A1C is very low. It's like 0.5 to 1%. Now, the reps will show you studies that if you combine it with metformin, you may get a little bit above 1%, but overall, clinically, they do not do that. And the disadvantages of them is they're expensive. The other disadvantage is in elderly patients, if you take a look at these drugs, both, sitagliptin, Januvia, saxagliptin, is that a lot of them you have to renally dose adjust. The only one that you don't have to is linagliptin, has renal dose adjustments. And so in elderly patients. The other one is there's some drug interactions with CP3A4. Although these are rare effects, there is reports of pancreatitis, which could actually worsen diabetes, joint pain, and Stephen-Johnson syndrome, SJS. We see that saxagliptin may have the more strong drug interactions, so there is a strong 3PA4. May want to reduce the dose to 2.5. It's also some evidence may worsen heart failure. And because sitagliptin doesn't have a lot of those, it's become the more popular one on the market. The SLG2 inhibitors, which came out several years ago, they work in a new mechanism of action. They reduce the absorption of filtered glucose and lower renal threshold for glucose, and so they prevent they prevent the glucose from being reabsorbed in the tubules. And so this, because we have more sugar in the tubules, this is going to have an increased excretion in the urine of sugar. Now, the advantage of this drug, it doesn't seem to cause hypoglycemia. In fact, there's some reports you may get weight loss. And because you're getting fluid loss, you may see a reduction in blood pressure. But these drugs also are significantly expensive, and they don't seem to lower the A1C reduction by much, 0.5 to 1%. And these drugs, too, we have to worry about renal dosing, especially in elderly patients. The other disadvantage, and I think this is my opinion, especially in elderly patients, is because we have more glucose in the urine, we have an increased UTIs, which if we have somebody who has any bladder retention issues, like an elderly man with BPH, that even adds to the risk. There may be an increased risk for LDL. And the disadvantage is also there's an increased risk for maybe fungal infections and hypotension and dehydration. And so, and there's had been reports with some of the drugs like Farxiga increasing bladder cancer. So, doesn't mean that they may not have a place for some patients to be used, but caution needs to be done with these drugs. The other agents, which are actually injectable agents, is the GLP-1 receptor agonists. And the GLP-1 receptor agonists, they work by increasing insulin response from the beta cells. They also inhibit gastric emptying, reduce food intake, and therefore we may see weight loss with these drugs. These drugs work a little bit different than the DPP-4s, is because these drugs are actually mimicking incretins, which are depleted by the DPP-4 enzyme. What the DPP-4 inhibitor drugs that I just talked about earlier are doing is they're blocking that enzyme from decreasing incretins. And these drugs, compared to the DPP-4 oral agents, seem to be a lot more better in A1C reduction from the 1 to 1.5, and so they're falling into the metformin sulfonylurea range. And a lot of that has to do with that, maybe that one of the problems we see in the progression of diabetes is a decrease in these incretins. And so definitely if you're choosing from a cost standpoint, that these may have a bigger advantage over the DPP-4s. However, there has not been any head-to-head trials to show that. Now, the other downside of these drugs is they are an injectable. They do come as an insulin pen type of form. And they, are significantly expensive. And so when you start thinking about people and their high copays and what they're covered, and people that may be fearful of an injection. The one nice thing is we do have newer drugs that have come out, such as Trulicity, Tanzium, and Byrudian, which do have that you can do once a week dosing. So that is nice. They can cause a little bit of nausea and diarrhea, but the biggest complaint that I hear from patients, especially the weekly agents, is that they might get some soreness, pain on injection that can last for a day or two. Okay, so we've talked about the guidelines and monitoring. We talked about the oral agents. Let's take a look at explain the role of the different types of insulin therapies for a type 2 diabetes patient. Obviously, we have three types of insulin. We have rapid-acting insulin, we have short-acting insulin, and we have the intermediate basal type of insulin, the longer-acting insulins. And so the rapid-acting insulins, such as Humalog, Novolog, and Adipra, which Humalog and Novolog seem are what dominate. There's no clinical advantage really over Adipra and Humalog and Novolog, depending upon the patient's insurance. And one insurance may cover Lilly products, one other insurance may cover Novartis products, and so they are pretty almost significantly interchangeable, maybe a little bit different in onset and duration, but there really is no clinical significance in the difference between these two agents. The nice thing about these agents is that we're using these agents to help take care of postprandial sugars. So one of the things you remember that in fasting sugars, we like to keep them anywhere between 70 to 130 or 70 to 140. And we like to keep the postprandial, which is what are our sugars at least 2 hours after eating. We like to keep those at least below 180. And so the rapid acting insulins help take care of those postprandial sugars, whereas the longer acting insulins are focusing more on the overall what is our sugars when we're at fasting. And so these drugs, the nice advantage of these drugs when they came out is that I no longer have to wait like I did with our insulins 30 minutes before. I have to give it 30 minutes before I eat. I got to plan when I eat. These, because they're so very rapid acting, I give my shot right when 10 minutes before I'm about to sit down to eat, and boom, they're already taking effect. We do still have the short-acting insulins, the Humulin Rs, the Novolin Rs. The disadvantage of these drugs is that there may be more hypoglycemia associated with them, but you have to time that out. The one advantage over the short-acting may have over the Humalog and Novolog is they are at least a little bit cheaper in terms of cost compared to the rapid-acting. So if cost is an issue, that might be around to think about for a patient, although they are not as cheap as they once were. Your intermediate insulins, such as your Humulin N or Novolin N, they are what we used to really use all the time before we had basal insulins. And most of the time, these do have to be dosed at least twice a day. They're usually cloudy in appearance, and they can last anywhere from 16 to 24 hours, but usually it's about 12 hours that you get. And most of the time, it's recommended that these are injected at, if it's twice a day at breakfast and 30 minutes before breakfast or dinner. These also may be a little bit cheaper than our long-acting basal insulins, and so for somebody where cost is an issue, may be an alternative. So we do have our long-acting insulins, and our classic ones that we've had is Lantus and Levemir. We're going to talk about Tresiba when we talk about new drug therapy. So there is, and then we'll also be talking about the newer biosimilar to Lantus that is also out, and we'll talk about those in the new drug therapy. But they all work very similar. The goal of these is to mimic what our insulin is doing when it's being released from the pancreas during even the hours when we're not actually having a physical meal. Their onset is 1 to 2 hours. The advantage of these are they're almost basically peakless, where Lantus is pretty much peakless, where Levemir has a little bit of a peak. A couple things, they cannot be mixed with other insulins. They are also a sub-Q injection, and a lot of times we recommend these are be giving at night. And because they are clear, they can be mistaken for a short-acting insulin. But a lot of these, not a lot of these, they all come as an insulin pen. Lantus may cause more pain in injection site due to it has a lower pH. We still have mixed insulins. I still can remember the day I told you in one of my earlier talks about working at a diabetes clinic in the VA. And I remember our type 2 diabetics, we usually would just, when they were going to insulin, we'd put them on 70/30. And what we would do is most insulins are dosed by anywhere from 0.5 unit to 1 unit per kilogram per day. Most of the time you go cautionary, you go 0.5 units. So you take 0.5 units times what they weigh. And what we used to do is 2/3 of the dose would be given at breakfast and 1/3 of the dose would be given at dinner time. And then you would slowly adjust. The downside of the mixed insulins that is that it is nice that you only have to give one shot if you're looking to treat somebody with postprandial, you know, but the downside is as you slowly try to go up in the dose, eventually you may have to split them apart. So the NPH and regular, obviously we have our regular insulin, and the remaining mixes have both intermediate NPH and rapid acting insulin. So what do the guidelines of insulin therapy recommend? Well, usually we start, when do we put somebody on insulin therapy? Usually when we reach a point where we can't get their A1C below, definitely below 8.5%. And we've maxed out on other oral therapies, or we've reached a point where we've maxed out on cheap oral therapies, and now the patient's weighing on, do I need to add insulin? So usually we initiate basal insulin. We still keep the oral insulin, oral agents. If we're on a sulfonylurea, we may over time think about reducing that. If we've had significant weight loss and we're on Byetta, we may specifically think about taking that off too. So usually we start anywhere from 10 units or 0.5 to 0.0 units per kilogram per day with basal insulin. We adjust anywhere from 10 to 15% or 2 to 4 units once or twice weekly to reach our fasting blood glucose target. And that fasting blood glucose target is somewhere usually between 70 and 140. And we also address issues if the patient is having hypoglycemia issues. If they're not controlled, we may consider adding another agent, such as a GLP-1. But like I said, a lot of times it's reevaluating. And every time we reevaluate the person's insulin, we should be reevaluating their lifestyle modifications and their dietary modifications. So let's take a look at the very end here, a study example, and how we as pharmacists can educate patients and techniques to help improve diabetes. So we have CW, who's a 63-year-old white female. She presents to the doctor's office for her annual diabetic visit and a lab review. She complains of a productive cough that has been bothering her for the last few days. At today's visit, the patient's diabetes was reviewed and discussed. A diet and exercise plan was also reviewed. CW was referred to the pharmacy by the physician because they have a strong collaborative practice relationship going on, and they would like them to evaluate their medications and come up with a way to make her more adherent, and this pharmacy offers a multi-blister packing system. And so during seeing the patient, an MTM type of session occurs, and it seems that CW appears very confused regarding all the disease states and medications. She has a very low literacy, has trouble reading and understanding her health concerns, so that is why she is an excellent candidate for blister packing. The pharmacy reviews all the disease states with her and her medications, and she agrees to the blister packing and demonstrate of how to use the blister pack. Here's her medications. She's on atorvastatin, metformin, glimepiride, Novolin 7030, levothyroxine, buspirone, loratadine, meclizine. So when you take a look at this patient, what are some concerns? Well, one, we're going to talk about in the next lecture, is she's on atorvastatin, but it is actually low intensity, and depending upon her cardiovascular risk, her mother has a history of heart disease, then we may want to increase her atorvastatin to anywhere from 40 to 80 milligrams a day. She's already maxed out on her metformin. Patient has issues with affording the more expensive insulin, so the physician had put him on Novolin 7030. However, Novolin 7030 does not come in a pen anymore, so this pharmacy is actually helping the patient draw up her insulin syringes because she's having difficulty. She has very difficulty reading the insulin syringe. So she's currently on 28 units sub-Q twice a day. The pharmacist reinforces and counsels with her that she needs to take this shot 30 minutes before breakfast and dinner. The question is that the other thing that was counseled during this time was how to test your blood sugar, because it's questionable whether or not the glimepiride needs to be on. The patient's hemoglobin A1C was around 7.4, and so over time, on the next visit, may recommend to discontinue the glimepiride due to the decreased risk for hypoglycemia. Also, too, during the MTM session, reviewed to see if the patient had any allergies. I apologize. Her A1C was 8.5%. It has been coming down since they switched to the other insulin and actually had been drawing up the insulin. The patient also was unsure of a pneumococcal vaccination or TD or hepatitis B, and so those were sent to the physician and recommended that she get these shots in the near future, and also letting them know that the pharmacy can give those shots. Patient's renal function is actually pretty good, and her thyroid's pretty good right now. And just a note, so what do we do right now? We recommended vaccinations. We provided disease state medication education. We trained them how to use a glucose meter, and we'll follow up and evaluate whether or not the patient does need to continue on the glimepiride. The other thing is also talking to the patient about a dietary consult. The patient did go through diabetes education classes, but because of her low literacy, couldn't use another reinforcement of dietary intake. Now, just a side note, this patient is actually a patient that I saw along with my students in clinic. And in the last couple of weeks, I get a call from the patient, and the patient has called me twice in the morning and said, I'm a little bit worried. I checked my blood sugars and they're around 80. And I said, okay. And I asked her, is she having any hypoglycemia? And she goes, no, I feel pretty good. I'm just worried. I've never seen a low number like that. So, just to share with you, the points of that is through education, through helping address adherence, think about the impact we can do as pharmacists. And think about, as we talked about in the prior lectures, collaborative practice, diabetes education. The diabetic patient is one of our coveted types of patients because they need our help. We can have a win-win with them and constantly dealing. Now, I do know, if you want to talk about insulins and reimbursements and stuff like that, there's a lot of issues there. We need to fight on the pharmacy side. However, helping our patients, there's lots of opportunities and alternatives, and these patients are going to unfortunately have to be on medications for life, but trying to get that patient to be on the right medications is the best outcome, and thinking about becoming diabetes accredited, because we definitely need more diabetes educators. So in summary, think about this. Why do we push, and when I'm educating a patient, hemoglobin A1C? Well, if you take a look at, if they're testing their blood sugars, have them bring in their meter. And if they're testing, at least on a regular basis, we want to test their meter, make sure they're, the time's right, the date's right. But look at the correlation. If their estimated average glucose in that meter, is around 150, they're doing pretty good. Making sure that they're following up with their doctor and getting their A1C checked every 3 to 6 months. If you get into point of care testing, get a CLIA waiver. You may be able to do that test yourself. Making sure they're getting their blood pressure checked, their cholesterol checked, checking their feet, having eye appointments, getting their annual flu shot, getting a pneumonia shot, and also getting both pneumonia shots eventually. Talk with them about eating healthy, smoking cessation, taking an aspirin a day, and then also evaluating their blood pressure regimen. If you go back to our patient here, if you notice this patient is not on anything for blood pressure currently, her blood pressure is high, and we would want to think about possibly adding an agent for blood pressure, such as maybe an ACE inhibitor or ARB. I forgot to note that. Also, reiterate with the patients when we're educating them about the long-term complications, and that's why we want to take that control. Also, make sure that this is an opportunity, and there's lots of different I know that there's different monitors that that aren't good business, but there are a lot of monitors out there that can be a win-win for us, and most of all these monitors do the exact same thing. And so I encourage you to do that. The other thing that a lot of these monitors do is they have software that you can download and analyze. We do offer that for our patients. They can come in, we'll download their report if they don't feel comfortable doing it at home, and we can share with them how their readings are doing. Also, too, educate them what affects their blood sugar, such as their diet, medications, and then also review the signs and symptoms of hyperglycemia. And obviously, we've already talked about the symptoms of hyperglycemia, such as extreme thirst, frequent urination, dry skin, hunger, blurred vision, drowsiness, and decreased healing. Hyperglycemia, obviously, what are the causes? Too much food, too little insulin or diabetes med. Illness and stress can do that too. And so, wanting to make sure that the patients talk to their doctor about an illness or stress plan of what to do when those sugars are high, and talk to them about the long term risks of being high. Obviously, what they can do is test their blood glucose more often. Don't wait to call the doctor if your blood sugar is over 200 milligrams deciliter for several tests for 2 days. Hypoglycemia is another important one, especially if we have patients on insulin or agents that can cause hypoglycemia. Obviously, we got the shaking, the fast heartbeat, sweating, dizziness, anxiety, hunger. Now, the one thing is if your patient is on a beta blocker, a lot of those symptoms can be masked because most of these symptoms are driven by the sympathogenic system, whereas sweating is a parasympa symptom. And therefore, if I have somebody on a beta blocker, counsel them that some of those symptoms could be masked, but if they notice any sweating like the palms of their hands, they should be checking their blood sugar. What causes low blood sugar? Too little food, too much of their medicine. Maybe also they're starting an exercise activity plan. They really should check their sugars, and if they're going to start running, we're going to talk about here in a second of what can raise your sugars. Because the worst case scenario could cause unconsciousness, confusion, and shock. So the 4 steps to treat hypoglycemia is we need a quick sugar that's about 10 to 15 grams of carbohydrates. Recheck the blood glucose in 15 to 20 minutes and repeat the treatment if necessary. And if your glucose is normal, what you want to do once you've raised it back up, eat a protein meal or snack to level out your sugars. If you have symptoms but your blood glucose is over 70, have a snack. So, what are some good classic snacks? 4-ounce half glass of orange juice, 2 to 3 glucose tablets, 3 to 5 peppermint candies, 1/2 can of regular soda, not diet, half 8 ounce of milk, 5 to 8 lifesavers. Once we use one of those to raise our sugar, we recheck our blood sugar in about 10 to 15 minutes. If it's normal, then we want to eat a protein snack like a half a meat sandwich, crackers and cheese, peanut butter sandwich, or crackers. And so even if we can't carry around a half meat sandwich or a peanut butter sandwich and crackers, we can carry around, a baggie full of crackers and cheese when we're out and about. Sugars to avoid, foods to avoid when we're trying to treat. Chocolate, even though it has sugar in it, it takes too long to be absorbed due to the fat in it. And a lot of these other ones are too low in simple sugars that it takes too long to produce. The last thing that we can do, most importantly for our patients, is educate them how to use insulin, and regardless if it's an insulin pen or a valve. So if it's an insulin pen, some key tips is teaching them how to prime it, how to put on the threaded pen tip needle, how to remove it, and how important it is to replace that needle every time. I have some patients that are older patients, they don't replace the needle. That just makes me cringe. If they're using an insulin syringe, that they draw back on the syringe how many units they're going to be drawing up. They want to inject that same amount of air into the valve and draw it up. And obviously, the other thing we want to teach them is sterile technique. So the other thing, too, I think is so important is teaching them to rotate their sites. There's pictures of where those sites are. I was doing a diabetes class with a patient, and this gentleman was arguing with me that his diabetes got worse when he started losing weight. So I asked him when we got to the pen part, how do you lower, where do you give your shot? And he pointed to the back of his arm, and he goes, I give it here. I said, well, where else do you give your shot? He goes, I give it here. And I went over there, and right there in his arm was about the size of a quarter, a hard, fat pocket. And the problem is that if we don't rotate those shots, we can develop those, and it can affect absorption. There are several assessment questions that you can read through on this handout during the live session. Greg will review those for you. Thank you, and please feel free to email me if you have any questions. Have a good day.